Dr. Deepak Patel is here. Okay, please be ready. You will be the next speaker.
Start, sir. Yes. Good morning, judges. So my paper is on proficiency assessment of trained vision center technician in neuro-ophthalmological disease screening. As we know, telemedicine enables the remote access to the specialized neuroscientific care, and vision center technicians plays a pivotal role in early detection and referral processes in rural areas, and plays a key role in diagnosing the vision and life-threatening diseases and collaborating with the base hospital for the improved patient outcome. The main purpose of this study is to evaluate the overall agreement made between trained vision center technician and neuro-ophthalmology specialists. The objectives were to compare the diagnostic accuracy and to investigate the factors contributing to any discrepancies. This is a geographic map showing the study location of 17 vision center. The average distance from the base hospital is around 50 kilometers. So how essential are vision center in identifying the neuro-ophthalmological visit? A patient enters the vision center and patient is registered, and the relevant clinical history and anterior segment examination is made with slit lamp, and posterior segment examination is made by non-mydriatic fundus photography, and the relevant details were communicated to the base hospital to a junior resident, and the referral process is initiated. So the study design is a retrospective hospital-based study of 1 year duration, and the relevant details are collected from the EMR record. So out of 554 referral, 331 visited the neuro-ophthalmology clinic, and the mean age was 45 years, and the most common complaint was defective vision, followed by double vision, drooping of lids, field defect, headache, and eye pain. The majority of them were females, contributing about 56%, and most were distributed in the middle age group. The average time to reach the base hospital, 59% reached the base hospital less than 3 days. And they are truly neuro-ophthalmological diseases? Yes, the 70% were confirmed to have neuro-ophthalmologic diseases. The pathologies were categorized into afferent pathway disorder and efferent pathway disorder. So among the false referral, pseudopapilledema was the most common cause, about 9%. Among the afferent disorder, nutritional optic disc pallor was the most common, about 77%. And cranial nerve palsies were found to be more number in the efferent disorder, contributing to 8%. Among the vision-threatening diseases, ischemic optic neuropathy found in a large number, and in the life-threatening diseases, intracranial space-occupying lesion are found in large number, about 7 patients. CVA from a vision center. Yes, we found around 5 patients referred from a vision center in a 1 year period. 3 had homonymous hemianopia and 2 had cortical blindness. Among the cranial nerve palsy, 6th and 7th nerve were found to be more common. The overall agreement in the neuro-ophthalmological disease diagnosis made by vision center technician is 66%. And for afferent disorder is 66% out of 297 cases, and 67% out of 36 cases. There is a excellent agreement in lid, and a fair agreement in pupil abnormalities, and good agreement in extraocular movement and disc abnormalities. Under most of the studies, the average age was meaning from 45 to 56, and females were more common. The most common query was a vision and visual field disturbance, and the most average time to reach is less than 3 days. And comparing the recent studies, Conway et al. And Delay et al. Had excellent agreement, and Timothy et al. And our study had good agreement in diagnosing the neuro-ophthalmological diseases and clinical findings. Coming to discussion, to interpret optic disc photograph may be challenging. 61% disc abnormalities agreement was met in our study. Conway et al. Emphasized there is a need for enhancement in technology, and in our study we matched visual fields perfectly for all cases, exceeding the consistency reported by Felix et al. So hereby recommend the policy makers to integrate tele-neuro-ophthalmology into stroke system for improved patient outcome. Concluding, there was good agreement between the findings of VC technician and neuro-ophthalmologist, and trained technician can help in early detection and referral to the higher center, and it will help patients in the remote places, especially rural areas, to assess the high quality, cost effective neuro-ophthalmologic care. And these are my recommendation for tele-neuro-ophthalmologic care: color vision, HD fundus photo, central field visual field examination by germ screen, best corrector visual acuity, swinging flash light test, and regular CME to update about the neuro-ophthalmological disease screening. I hereby thank AIOC Scientific Committee for giving me this opportunity to present here. These are my references. Thank you.
Why are you recommending for Jerem screen?
For visual field testing, ma'am.
Yeah, but why you are not recommending for Humphrey or other things?
No, for cost effective, ma'am.
This studies were with one vision center or with many vision centers?
17 vision centers, sir.
Okay, so was the training and the capability of all the vision technicians equal?
Yes, sir. So the vision center technician will have a 2-year extensive training in the base hospital.
Okay. So out of how many patients seen, you said 544 were referred. Out of how many patients 544 referrals were required?
331, sir. 60% were.
No, what I'm asking is, out of total how many patients 554 neuro referrals? Like what is the total number of, what is the approximate total number of outpatients all these vision centers would have seen together? That is what I'm asking. You don't have the data. It's okay. Why
So
I'm asking
averagely
is,
they see around 50 patients per day in single vision
okay.
centers.
So why I'm asking is, how far are neuro-ophthalmic illnesses a public health issue to be tackled at a community level? So that is my, but all these patients underwent Jerem also. Jerem
Yes, sir.
screening
Yes,
also.
sir. Yes, sir. Color
All-
vision, Jerem.
Whoever had the vision technician had a doubt that they may have a neuro problem, they will do a Jerems also.
Yes, sir. Yes.
Okay.
How many of them are referred for the imaging, either CT or MRI?
So
And how they were, I mean, it was decided?
no, after they're coming to the base hospital, the anterior segment and posterior segment examination done, RAPD and fundus examination, then the neuro-ophthalmologist will decide whether neuro imaging is needed for this patient or not.
So very well timed.
So in the life-threatening diseases, intracranial space occupying lesions were found 7 in number, and cortical vein thrombosis about 2 in number were identified. So like that data.
So very good study, very well timed presentation also. So in all the vision centers, Jerem screen was there, you're saying.
Yes, sir.
So this diagnosis was made by the VC technician or that junior resident on the phone call?
No,
Video call.
the referral process is initiated. The
So
data,
who made the diagnosis? The VC or that doctor?
the both will make.
Both will make.
So the
how
VC technician will tell the finding. So if it is, they will agree on term and they refer.
okay, so like you said, ICSOL was one of the diagnoses. So how
So
did they make?
66% agreement were made when comparing with the neuro-ophthalmology specialist.
Okay. So you said ICSOL was one of the diagnoses. So how did they make that diagnosis without an imaging at that time? You said intracranial space occupying lesion is one of the diagnoses. So without any imaging at the VC, how did they make that diagnosis then?
So they will be referred as a papilledema.
Okay. So maybe you can
cranial
change that
palsy.
in your study.
Yeah,
no?
yes. The final diagnosis I will.
Okay.